Chapter 23, blood vessels and circulation, and this is going to wrap up our cardiovascular unit before our next exam. So anatomy of blood vessels, blood pressure, systemic circulation, review the heart and how it relates to systemic and pulmonary circulation, and there's really just one slide for fetal circulation. I believe you have an entire learning objective about fetal circulation, so I'll just highlight a couple of tiny details about it. It's not going to be a big paragraph of information for that learning objective. It's going to be a couple of details. So we already know our operational definition. Our brand new definition for arteries and veins is that arteries carry blood away and veins return to. We're going to add on together some anatomy differences between arteries and veins as well. Histologically, they are different. They do have the same layers, but different compositions of each of those layers, different thicknesses, different densities, things like that. We are going to go Gesundheit from very, very large arteries that leave the heart to progressively smaller arteries, to arterioles, to capillary beds, and then it's going to go back from small to large again. So here's your basic anatomy of arteries and veins. You have three tunics, three layers. It's tunica intima, tunica media, and tunica externa. So tunica intima is the deepest layer, so that's going to be the layer facing the lumen, and usually that's a pretty shallow layer, maybe just one or two layers of simple squamous epithelium, or stratified squamous epithelium, usually squamous though. And then we're going to go to the tunica media, and that's going to be a muscular layer. So that's going to be smooth muscle, and that contraction of that smooth muscle is going to control vasodilation and vasoconstriction, two concepts we're already familiar with at this point. And finally, tunica externa. And if this doesn't sound particularly interesting or valuable, it turns out it really is. One day you're going to see the Marfan syndrome, for example, which is a connective tissue disorder. These three layers are held together with connective tissue. If this layer is weak in an individual, this can tear apart, and blood can seep in between these layers, between the tunica intima and tunica media. You can have blood getting in between these layers, and that blood is then very forceful, and it's going to continue tearing away between those layers. And then it can become static. It can be hard for that blood to move on. Then it becomes a blood clot. So you can have a giant blood clot hanging out in between the walls of your arteries. That happened to me once, even though I don't have Marfan's. With Marfan syndrome, you're worried about that in the aorta. That's actually a relatively common event for somebody with severe Marfan's, is for that to happen within the aorta. And if that happens within the aorta, their blood pressure drops and they hit the floor. And that's a cardiovascular absolute emergency. They're going to need immediate thoracic surgery. It's instantaneous. So that actually does have clinical application. It is not arbitrary that I'm just saying, hey, learn these three layers. That has a reason. The veins have, you guys are all like dumbfounded and silent right now. Do you have any comments about that or questions? Yeah, okay. The veins have basically the same layers, but anatomically you'll notice that the lumen is much wider in the vein. So here's your tunica intima out here, and then you'll notice the tunica media is practically not there. It's there. It's very, very shallow compared to the tunica media on this side. You can see then many, many layers of smooth muscles here, and then just sort of this paper thin, it's not probably a good way to phrase that, but this very thin layer of smooth muscle here. So that's not going to have as much contractile force. That's not going to be able to pump blood along. I see you, Debbie. I'll get you in a second. That's not going to be able to pump blood along. It's not going to be able to vasoconstrict or dilate as powerfully. It's there, but that's about it. And we also have valves in here in the venous side. We do not have valves in the arteries. We have valves only in the veins. And then you have a tunica externa here as well. So those are the differences: wider lumen, valves derived from endothelium within the veins, narrow or shallow tunica media in the veins versus in the arteries. All right, question, or did I answer it?
No. So going back to what you were talking about, how like if the connective tissue is pouring, you can start to tear. Would that be the same thing as the abdominal aorta tear? I think it's called like a AAA. I don't remember what it's called.
So yeah, AAA is an abdominal aortic aneurysm.
Would that be the same or is it different?
It would be related to weak walls of your aorta. And I'm not sure, I'm not familiar if it's something that people with Marfan's are specifically prone to. But yes, those are particularly dangerous.
Well, yeah.
For very similar reasons, yeah. Mm-hmm. Yeah, you bleed out really fast from your aorta. That's a big part of it, absolutely. Okay, tunica intima, usually simple squamous epithelium lining the blood vessel lumen. That's a very thin and delicate layer. Usually our simple squamous is about letting things through. And in some cases, with things like white blood cells that we'll talk about next week, that's exactly what it's there for. It's to let things through. So as those blood vessels get smaller and smaller, it makes it easier for white blood vessels to get through those layers. And then that should say areolar, not areola. Areolar connective tissue is connecting that tunica intima to the tunica media. Don't forget this vocab word right here, endothelium. That's the same as an epithelium, but facing the inside, hence the word endo. So all endothelia are types of epithelia, but not epithelia are endothelia. Did that phrase make sense this early in the morning? Okay. So you can always call the inside surface an endothelium, especially if you want to be brief and just say, I'm definitely describing something facing the inside versus something facing the outside. Tunica media, that's where vasoconstriction and vasodilation are going to occur because of sympathetic and parasympathetic input to that smooth muscle. And then tunica externa, this is going to be variable in size. If that blood vessel is within an organ, like for example the liver is very vascular, there are many blood vessels within the organ, and there's no space between that blood vessel and the rest of the tissue of that organ, that tunica externa is going to go right into that connective tissue layer of the rest of the liver. So that's going to help anchor it within that liver. Some blood vessels, and I think this naming convention is awesome, some blood vessels are thick enough that the walls are so thick that their oxygenated blood is not enough to supply the entire thickness of the wall with blood. So some blood vessels have their own blood vessels within the walls of those blood vessels. And those are called vasa vasorum. Isn't that a cool, it just means vessel, right? I think that's really cool. I love that naming convention. Like, what are we going to call these vessels in the vessels? What about vasa vasorum? Vessel, sounds good to me. Okay, let's have an early lunch. That's how that went. And yeah, it's really cool. And histologically, you can see them in places like the aorta, for example, which is very, very thick, which you saw on the sheet parts last week. You saw the thickness of that aorta was a big part of that. Histologically, this is, I believe, from your textbook, and it is very, very textbook looking. You can really visualize that there's a vein here and an artery here. Here's, I think, what I consider to be more common and realistic view of what arteries and veins are going to look like, and I'll show you what I mean by that in a second. So here's an artery. You can see the smaller lumen. All of these little darker dots in those are red blood cells. And you can see, if you're really remembering your histology well, you can see your smooth muscle that's going around circumferentially, this blood vessel. And let's see if I can visualize. There's tunica externa just on this outermost layer right out here. Now the vein, by comparison, has a much wider lumen, and the layers of the blood vessel itself are quite small. And maybe you recognize this tissue out here? It's a fun one. What's that? Adipose. This is all adipose. So this is some blood vessel embedded in fat. So a likely place for this would maybe be the hypodermis or something like that. Very vascular hypodermis that we already know about. I don't know for sure that that's where it is, but that's a possibility. Now by contrast, these are actually smaller blood vessels. The way I usually see veins in histology is compressed and flattened like this, which is why I thought it was important enough to give you a different view and a different slide. They usually are not patent and open like this. Those delicate walls mean that those tissues are going to kind of compress them. And I think that actually has functional significance. So that's why I gave you two pictures to start to understand that. This is a much smaller artery. You can see the circumferential smooth muscle, and you can see the purple nuclei that are kind of flattened. And there's just a handful of layers. There's like 5, 6, 7 layers of those smooth muscles, whereas this, we're looking at, I can't really count that, 30, 40 layers of smooth muscle over here. So these are much larger vessels than these are. Are we able to appreciate that? Okay. I think that's it. Now we'll talk about the sizes of arteries and their naming conventions as they change size. From large to small, we start with elastic arteries. So the aorta would be an example of an elastic artery. That means it's going to have abundant elastic tissue. So in this histology slide, they've stained specifically for elastin, and that's the black stuff. When you stain elastin, it comes up black. So you can see this layer right here that's very dense in elastic tissue, and this layer right here that's very dense in elastic tissue. So again, in a place like the aorta, that's right off of that heart. It's the first place that heart goes to, right, is that aorta. So that's going to be the area of very highest blood pressure. So it needs to be pretty distensible. It needs to be pretty flexible and elastic. Then as we get smaller, we lose some of that those elastic fibers, and we move on to muscular arteries. And then we get smaller arteries and then arterioles. And there are some nuances in between these, but we're just going to stick with these 3 sizes. So by the time we get to arterioles, we're just talking about something like this. This is the arteriole. This is an arteriole. That's probably a vein over there and a vein over there, or a venule, rather. So we're just looking at, this looks like 3 layers of smooth muscle for that arteriole. So as we leave the heart, it's elastic arteries, then muscular arteries, then arterioles. Then we move to capillary beds, then back up to venules, small and then medium-sized veins, and then large veins. The naming conventions are a lot easier on the venous end than they are on the arterial end. Now I want you to be a little bit careful with this, because sometimes when we see an arrangement like this and we want to categorize things and put them into lists, we go elastic artery, large vein, muscular artery, medium-sized vein, arteriole, venule. But that's not the order they're in, that's just the comparable sizes, right? So you do need to, jazz hands, know that we're going from big to small and then small to big. So if you're listing them, that is the order I recommend that you list them in. You go from big to small, then small to big. Make sense? You're going from big to small to big because I want you to know the order in which blood is flowing through it. And it's going from the elastic arteries to the arterioles to capillary beds to venules back to large veins on its way back to the heart. And sometimes when I ask students to order that in an exams type of scenario, they list them logically from largest to smallest. So I'll say, what's the order of veins and arteries? And they'll say large vein, elastic artery, or, muscular artery, medium-sized vein. And they'll just do it because it's nice and logical, not because that's the order it goes in.
So you mean that's the order it goes in the body?
Yeah, and it would be phrased very carefully on an exam, like starting from the heart, leaving to the systemic circuit, and then coming back to the heart. Give me the order of these blood vessels in order. Yeah. Something along those lines. So again, elastic arteries, abundant elastic tissue for extensibility and elasticity. And those branch into muscular arteries, which would look muscular but less elastic, and those branch into arterioles. Let's see, I think I've got a little bit more specific stuff. Proportionally thicker tunica media on muscular arteries compared to intima and externa. And again, arterioles. So this is the largest part where that autonomic innervation can have an impact on our blood pressure. This is where vasoconstriction and vasodilation are really going to happen. with the most effect on the way blood flows through your body. So sympathetic innervation, those adrenergic receptors, are going to cause vasoconstriction, sorry. We talked about strictures yesterday in patho, so that was accidental. Causes vasoconstriction. Now, you have a tube that is relatively thick, and you have the same length of tube that is relatively thin, and you have the same volume of fluid in this tube as you have in this tube. Which of these fluids is under more pressure? In the smaller tube, that's a lot more pressure exerted on the walls. And that is why vasoconstriction is going to correlate with elevated blood pressure. It's the pressure of the fluid of the blood against the walls, and if it's in a tighter space, then by definition it's a higher blood pressure. Does that work for you guys? You're going to have to correlate a lot of these concepts today. You're going to have to connect the ideas of vasodilation, vasoconstriction, blood volume, blood pressure, and a number of other factors to each other.
So when somebody has higher blood pressure, chances are their blood vessels are smaller.
Yeah, what we're going to learn today is that blood pressure is multifactorial, many factors playing into it, including absolutely vasoconstriction of the arterioles.
So when you're on blood pressure medication, does that then relax is that the whole point of it?
Absolutely. That's one of them. So you could be on something like beta or alpha adrenergic blockers. And what you have seen briefly before and will see again is that you have alpha adrenergic, beta adrenergic, 1, 2, and 3 in different locations. And one of those types of adrenergic receptors is on these arterioles, right? So if you're taking beta blockers, one effect of that may be vasodilation. Yeah, blocking that sympathetic innervation. Yep, absolutely. So that feeds right into pharmacology. It's not even off topic, which is why I didn't press pause on here. It's totally related. Totally why I'm making you learn this. 100%. Parasympathetic innervation, therefore, would cause vasodilation. So a big part of blood pressure medication is absolutely messing with your autonomic nervous system and innervation. Okay, capillaries. Capillaries are where gas exchange is going to occur. So we're going to have just a simple squamous epithelium for your capillary beds. It's going to be as narrow as it can possibly be. Does anybody recognize this type of tissue out here from histology? It's not smooth muscle. It is striated. What's a striated type of muscle? Skeletal. It's not branched, so you know it's skeletal. Absolutely. So this isn't a muscle. This is a capillary bed within some kind of muscle somewhere. And there you can see a single red blood cell, and you can see the scale of that single red blood cell. This capillary bed is just wide enough for blood cells to make it through single file. And because that capillary wall, that simple squamous epithelium, is simple and squamous, one layer of flattened cell, that means that when oxygen is diffusing from here to here, it really does not have very far to go. And one thing to note is you see illustrations like this. You see illustrations like our blood vessel model over there, and you visualize the large-scale blood vessels very easily. It's harder to visualize what's actually going on with the capillary beds, and the hardest part of this is understanding that the capillary beds are by far the most abundant. They are by far the most surface area of blood vessel in your body. So even though they are tiny, they are literally just permeating everywhere. I mean, when you blush, that's because your your blood is brought to your capillary beds, close to the surface of your skin. So they are just permeating everything. So you have far more surface area in your capillary beds than anywhere else. It's absolutely a vital piece of information for you because it's going to tell us a lot about the way blood flows through capillary beds, what's going to happen to blood pressure as it flows over this very broad area. That's going to be very important for you. Now the structure of capillary beds is that there's going to be an arterial end and a venous end. And usually there's going to be some kind of thoroughfare channel. So not all of your capillary beds will be perfused at the same time. What's perfusion? What's that? So oxygen exchange is happening because blood is where? Versus not where. So that perfusion means there is blood in that blood vessel. If a blood vessel is perfused, there is blood in it. There will not always be blood in every part of your capillaries. So we will shunt blood from one place to the other depending on need, depending on tissue need. That's the purpose of that thoroughfare channel. We can still have a connection between the arterial and venous end, even though our metabolic needs are not very high in this area right now. So this might be, let's say you're in rest and digest, and you're eating a big meal, your GI tract is filled with blood right now. That's all perfused. But your skeletal muscle, some of it you're needing, some of it you're not. You're just kind of lying on the couch in a food coma, right? So it's Thanksgiving dinner, right? You just had Thanksgiving dinner. Your blood's in your GI tract, it's not in your skeletal muscle so much. So you'll have enough oxygen exchange for that low need in that area. But otherwise, a bunch of your capillary beds are going to have constricted smooth muscle around the capillary beds, and they will not be perfused all of the time. And then you start running from a bear, and this becomes perfused, and we shunt it away from your GI tract. So in your GI tract, then it would look like this. So far, so good on that? Okay. Do you believe me about the capillary beds having a very, very broad surface area? We can look at some more pictures. I can prove that to you more. I feel like it does need proving, even if you guys nod that you believe me. It needs to be proven. Okay, types of capillaries. You've got continuous capillaries, fenestrated capillaries, and sinusoidal or sinusoid capillaries. So what visually is the main difference between these three things? Tissue types specifically, what about them? Closed to open, exactly. So in places in your body where you need to control what makes it in and out of the bloodstream, you're going to have continuous capillaries, and this is going to be most common. This is going to be in most places. This actually has tight junctions between the cells so that they have a lot of control about what makes it through. You can even see they're using pinocytosis to transport things through that capillary endothelium to the external environment. It's being illustrated there. What's a fenestration? A hole, yeah. Fenestrated means there's tiny little holes. So this is just basically going to let more things through. So pores, fluid exchange, but there's still a basement membrane. There's still an amount of control about what makes it in and out. And then sinusoidal or sinusoid have very large gaps. If you are a blood cell, you may actually be able to make it through these sinusoids. So this is going to only be in places where we need to get the blood cells in and out very easily. So next week we'll talk about lymphoid after our exam, and we'll talk about how the spleen is going to filter the blood. It can only do that if the blood cells leave the capillary beds in the spleen. So that's going to be a location with sinusoid capillaries. Now we don't want too much of this because we don't want to lose albumin. We're going to care a lot about albumin today. We don't want to mess with our osmotic balance. But we will have this in places where the blood needs to be filtered, where the blood needs to be exchanged. Motoring right along, I'm going kind of fast. Do you have any questions so far? So veins. This concept right here is very important. Remember that your veins have that wider lumen, and they have less smooth muscle, right? And they're also located in order after capillaries. So after that blood has gone through the capillaries, one thing we're going to see today is that it's slowed down a lot. And now it's in this wide open space. It's in here now. It's a lot of area for it. That means that most of your blood is going to be in your veins at any one given moment, most of the time. So it's your blood reservoir. It's probably the most sluggish in your venous system. It's the slowest here, and it's the broadest, no, I don't want to say broadest area because that's capillary beds. Again, widest lumens, where it's just kind of sitting.
Because it doesn't have as much as that tunica.
Yeah, precisely, because the tunica media is much smaller in veins. So again, we go from post-capillary venules and then venules, and it's on these smaller venules where diapedesis occurs, and what that means is that when a white blood cell needs to exit a vessel and go out into your tissue. Like we talked a little bit about the 5 white blood cell types. We've got our neutrophils, remember? Do you guys remember these 5 types? Never let monkeys eat bananas. So neutrophils, they're all leukocytes, they're all white blood cells. So the L is for lymphocytes. Yep. And then monocytes, basophils, eosinophils, yeah. So eosinophils, basophils, eat bananas, but yes. All right, so those guys, some of them are going to circulate through the bloodstream, and then when they are needed, like neutrophils, remember they go out into tissues, and they become things like pus when you have a scratch that gets infected. So those neutrophils are going to move through the venule wall most easily. And we call that diapedesis. You'll see this vocab word again, especially with a lot more specificity in patho. That means basically walking and traveling is what they're referring to. It's traveling in response to a chemical cue. So again, diapedesis, the movement of white blood cells, occurs through the capillary venules. Those merge to form veins, and again, these veins do have cusps. They do have one-way valves. And I already mentioned this is where the blood is most sluggish. This is where it's most likely to get stuck and become have a stasis sort of problem. The way that blood flows through the veins, some of it's just going to be from pressure from behind, but there's not a lot of blood pressure coming from behind. We just got out of those capillary beds. We're way slowed down. Our blood pressure is kind of low, and we have this broad area in the veins to work with. So in order for that to move, and again, we still don't have smooth muscle to move it along, it's going to move via 2 types of external pumps. It's going to respond to external pressures. So the skeletal muscle pump means that when you move your legs around, you have your skeletal muscles contracting, and that's just going to exert force against the veins. And because they have one-way valves, every time you squeeze that blood forward, it's going to be trapped forward. It can't go backwards. So that's the skeletal muscle pump. It looks like this. So this segment is being squeezed. This looks like your gastrocnemius muscle to me. I don't know if that's what it's supposed to be, but that's what it looks like. So if this portion of this blood vessel is squeezed, it can't go backwards, it can only go forwards. So that's your skeletal muscle pump. It pumps it forwards, one direction only. This is why they say if you're standing for long periods of time or if you're sitting for long periods of time, you should get up and move your legs around, because you're going to activate your skeletal muscle pump and actually move that blood forward. The other pump is the respiratory pump. And what this means is that while you breathe, you are moving some of your musculature. You're moving your respiratory diaphragm. When your respiratory diaphragm moves this direction, superiorly, it increases the pressure in the thoracic cavity. And when it moves down, it increases the pressure in the abdominal cavity. That means right here, the superior vena cava is being compressed, and that's going to push blood into your heart, your right atrium. And when you exhale, your inferior vena cava is being compressed. High pressure here, high pressure here, high pressure here, high pressure here. So we talked about the right atrium passively filling last week. So it ends up functionally being, it comes from the superior vena cava and then the inferior vena cava, and then the superior vena cava and then the inferior vena cava. And I think that's really cool. Is that cool? It's pretty cool. So it's just the way we evolved. It's all externally influenced. It's not that the veins have anything to do with moving things forward. They're just built to prevent backflow, and then we have to do stuff in order to make it move back to our hearts.
Is that why if your job, like if you have birth control, they say like not if you have job, if you like to sit around and stuff, you're more likely to get blood clots?
Yeah, so sitting for a long period of time, you're going to be more prone to developing blood clots because of that venous stasis, is what we say. That's why they say if you're on an international air flight, you should, there are exercises you can do just from your seat, and you should get up and move around the cabin every once in a while. Yeah.
Is that why, like, when you're pregnant, sometimes people faint a lot, like I did?
Probably a big part of that. So any kind of compression on that inferior vena cava, or those are the iliac veins we'll learn today. Yeah, absolutely. So pregnancy can absolutely inhibit return blood flow to the heart, 100%. It's not even a question. Yes?
How's that work when you're sleeping? Not really. I mean,
You're still breathing when you're asleep, and also you're lying down, so you don't have the gravity pushing that blood towards your legs all of the time quite as much. But yeah, and then people do toss and turn, and there's some function for that. There's actually, again, it's about sleep, so I could go way into this if I wanted to. I'm going to pause for a second. All right, that was the skeletal pump and the respiratory pump, which was the cause for our venous return to the heart after we've completely lost our blood pressure. We monitor blood pressure with our, say it with me, sphygmomanometer. I have to say it slow, otherwise I can't do it. All right, you have systolic and diastolic, which now we know we can connect to the ideas of systole and diastole. So systolic would be the pressure during ventricular systole. We're not specifying atrial or ventricular, so by definition it is ventricular, right? So systolic blood pressure is when that left ventricle is contracted. And diastolic blood pressure is when that left ventricle in particular is relaxed, diastole. Now this is just going to show you, there's our 120/80, sort of average or top of line of average, whatever you want to call it. It's kind of always changing. We have our diastolic and systolic that we measure, systolic and diastolic that we measure as close to the heart as we can safely measure it, which is going to be that brachial artery that comes off from that aorta very quickly. We'll learn today. So we measure it there, and then as we go to smaller and smaller blood vessels, that blood pressure is going to drop. And in the capillary beds, it's really going to bottom out, and it's never going to return until it gets back to the heart pump. That's all this chart is showing you. What's that?
So that's kind of confusing to me, because when your vessels are smaller, isn't there more blood pressure?
So that's a good question. When the diameter is getting smaller, at the individual level, yes, there's more blood pressure on it, but we're also increasing the surface area. So that's actually a wonderful question. Let me get to the surface area picture, and then I'll go back to this. So this is a small surface area. There's just one larger vessel, right? But then you've got dozens and dozens and dozens and dozens of tiny vessels. So it's the same volume in more vessels. The blood pressure overall is dropping. And also this shows you that the velocity is also dropping. That velocity does pick up a little bit on the venous end because of that skeletal and respiratory pump, but not the same as the blood pressure. And this is showing you the area, cross-sectional area. So really, we start with the aorta. That is like nothing in the aorta. I could take out I couldn't, but hypothetically, if I took out my aorta and laid it on the table, the area is like this, right? But if I took out all of my capillary beds and laid them flat, it would be football fields. It's a vast, vast area. So that's showing you how much of a peak you have in area within the capillary beds and smaller vessels. So even though you're right, then if we have the same vessel in the same location constrict, that increases blood pressure. But it would be the sum total of dozens and dozens and dozens, or hundreds and hundreds and hundreds of arterioles constricting. So it's a really good question. Okay, we're back here. A few more minutes. So blood pressure is going to have a lot of influences. You're going to have your autonomic nervous system influencing it. You're going to have the blood vessels themselves. You're going to have the heart rate and cardiac output. You're going to have, again, that autonomic nervous system doing your vasodilation and vasoconstriction. Your straight up blood volume. How much volume of blood do you have? And that's influenced by everything, including how much water you've had to drink today and how much salt you've eaten. I'm never going to make you do the math. You don't have to do math in here. Let me see if I can even remember what these mean. Pressure over resistance, I believe, is what that means. Change in pressure over resistance is, I think, what that means. It just is telling you that the less resistance there is, the less force there is. Is that right? No, more force. Sorry, inverse. More force, less resistance. And then when you increase your pressure, you increase your force directly. And again, that's going to be influenced by cardiac output and peripheral resistance. It's also going to be influenced by your end diastolic and end systolic volumes and your heart rate and everything that goes into cardiac output as well. All right, so you have baroreceptors. We talked about this during special senses. What is a baroreceptor? Pressure. Baroreceptors detect pressure. You, in particular, have a good baroreceptor in your heart walls, but also this is portraying your carotid artery. So this is this junction of the common carotid artery as it goes internal and external. So you have a baroreceptor right there, and that carotid artery is really close to your aorta as well. So that's going to be your body's pressure gauge that it receives information from. So that's pretty cool. It's got its own sphygmomanometer just hanging out right here. Is that cool? No? Nobody's impressed by that? Good job, body. So if it detects elevated blood pressure, which again could be anything from greater blood volume to some sort of sympathetic innervation, that's going to send that information to the brain, and that hypothalamus is going to utilize the parasympathetic division of the nervous system to cause vasodilation, and that's going to help us compensate for that change in blood pressure. And the opposite would also be true. If we detect low blood pressure, the hypothalamus receives that information, sends out sympathetic signals to vasoconstrict, and that's going to compensate for low blood pressure. Cool? Cool? Does it make sense? Give me some kind of thumb in some direction. All right, if we have high blood pressure, what do we want to do to blood pressure? Lower it. How are we going to, what's one way we can lower it? By vasoconstricting or dilating? Dilating. And if our blood pressure is too low, and it's too low, we can't even get it to our brain, it's so low. What's going to happen? How are we going to compensate for that? Vasoconstrict. That's all. There's going to be about 20 other compensatory mechanisms for this that you'll see over the course of the rest of your academic careers, but that's our first one. And I think this is a good stopping point for us.